Okay, so thank you all for coming to our first TheraPath virtual lunch and learn today. Andrea Marquez and I, she's been gracious enough to kind of co-host with me today. We're going to be talking a little bit about ketamine assisted psychotherapy, as well as kind of a collaborative care model utilizing a med management provider and a discrete therapist for ketamine assisted therapy. That's the model that we typically use internally and the model that we'll be talking through today. All right. So just a little bit about ourselves. My name's Arif Noorbaksh. Arif is fine, please. No Dr. Noorbash unless I'm writing you meds. I did all my training here in the UT system in Houston and Dallas. Currently reside in Dallas. My email address is here. If you have any specific queries or anything I can do to be of assistance, please don't hesitate to email. And I have no specific disclosures aside from to say that, and I think I've talked about this in previous videos. I've used ketamine personally for medical purposes to treat my own major depressive disorder. And so I'll turn it over to Andrea to introduce herself.
Hi, everybody. I'm Andrea Marquez. Similar to Arif, did my training through and my education through the UT system here in Austin. Been a clinical supervisor clinical psychotherapist for 18 years and then clinical supervisor for about 12. I don't have any disclosures either. One thing I will disclose though is I've done ketamine myself. I've done 2 cohorts for experiential and training. So some of the information you'll be getting today is based off of those 2 experiences that I've had. My email is also there in case any of you have any questions. I'm happy to support with any information because I do think, like with ARF as well, this is a really collaborative model. And I think in general, moving forward, this is probably the best way to go as far as having community and having a consultation opportunity as well. So I look forward to sharing my info with you and any questions you might have. Thanks so much for coming.
Thank you, Andrea. Um, so I'm going to dive right in with just a kind of a brief introduction of ketamine and Spravato for those watching that may not be as familiar with these medications. So I'm going to kind of approach it from a little bit more of a medical standpoint. We'll talk a little bit about kind of upcoming non-ketamine assisted psychotherapy models that are on the horizon, and I'll turn it over to Andrea. So a little bit about ketamine and Spravato. We call these psychedelic medications. They work very differently than a lot of other psychedelic medications. And there's a lot of kind of words on this chart you might want to review later. But the take-home message is that ketamine is specifically a dissociative anesthetic. And as such, the experience from ketamine for patients can be very different than the experience with MDMA or the experience with psilocybin. These are all very different compounds, and the experience for the patient and the mechanism of action and how beneficial we think they are for various things definitely varies between all these. But the take-home message here is that ketamine uniquely affects glutamate as compared to a lot of other medications we use that affect a lot of different other neurotransmitters like norepinephrine or serotonin or dopamine. There's a lot of active research in terms of how we, provision ketamine. And so this model that we're kind of providing you today is kind of our thoughts on this, but the jury's definitely out. So what's going to work best in terms of how we integrate ketamine and ketamine assisted therapy into the medical system, with what we have right now, how we provide this, I think is going to be dictated both by kind of logistical concerns as well as ongoing research that's definitely pretty heavy right now. Um, so a little bit about ketamine itself. So ketamine's an old drug. It's been around since the 60s. It was approved in 1970 as an anesthetic. The important take-home thing here is when we're talking about our model, it's not FDA approved for anything related to mental health purposes. It's purely an anesthetic as far as the FDA is concerned. And so getting insurance coverage for ketamine can be problematic for some patients. But there's kind of ways that a lot of providers are trying to work around that model to be able to provide ketamine services under the in-network umbrella. And there's also a lot of differences in how it's administered. So classically, it's been researched as an IV medication for mental health purposes, but I've also administered it intramuscularly, subcutaneously, sublingually to patients at various times. So the only mechanism or the path of administration that can't be used with ketamine is oral. So it always has to be a non-oral because the liver metabolizes pretty much all of it as soon as you swallow it. But this is one of the most effective treatments we have for depression right now, with the 50 to 70% efficacy. And there's a lot of adverse effects and a lot of risks, and we'll talk about those in just a little bit. Spravato is kind of the brand name version of ketamine, so to speak. So when we say ketamine, we're really talking about a 50-50 mixture of S-ketamine and R-ketamine, two very similar compounds. Spravato is just S-ketamine. It's more potent of a medication, and it's administered in the office only. It's an intranasal medication, so it's got to be pretty low volume, pretty potent to work intranasally. Just of note, I know some of you, we've talked about Spravato before in some of these previous videos. Very recently, some data has come out showing that Spravato is pretty effective without an antidepressant, and so the label's being changed so that moving forward at some point soon, it will no longer require an antidepressant in conjunction with it, which it used to in the past. But this is approved by the FDA. It is available in network and comes with very similar adverse events, which are disassociation, nausea, et cetera. So getting patients ready for those events is something that I know we'll talk about a little bit later on with Andrea. But I guess the point, the take home message here, and what the idea I'd like to leave you with, I think this chart kind of helps us really illustrate this. So this is from a company, it's a trade group called Psychedelic Alpha that follows the psychedelic industry. And each one of these icons represents a different psychedelic or psychedelic adjacent compounds that is currently being investigated. So you can see Spravato is right in the middle in the bullseye. It made it to FDA approval. The ones that are close by are right around, such as MDMA and psilocybin. And then you can see where everybody else is. But the take-home message is these are all very different medications. I think there's this idea that it's some of these are derived from plants, so it's plant medicine, so it's safer. I don't really ascribe to that model. I think nature has been trying to kill humans since humans existed. So just because it's natural doesn't mean it's necessarily safe. And all of these medications are going to come with unique risks in terms of drug interactions, in terms of medical comorbidities. And so the model of prescribing these in conjunction with a medical provider, I think is a really important one to maintain. And I know there's a lot of debate about that kind of in the community, the psychedelic community. People have very kind of almost religious views on these things. And so I think it's important to just kind of clarify where I stand. But I think in addition to the medical appropriateness for one of these medications, another adjacently important thing is the psychological appropriateness of the patient and their preparation for these, because these experiences, especially with ketamine, can be really uncomfortable. And so patients need to be ready. And with that, I'll go ahead and turn this over to Andrea.
Right. So thank you, Arif. So one of the things, though, I do want to add to what Arif said about the medication. So for instance, with the plant medicine idea, psilocybin currently, as it's being studied, at least here at UT and at Baylor, it's done in a lab. They're not giving active live mushrooms to people. It is actually a chemical compound created synthetically in a lab that's being administered. And so a lot of these medications are being made, not necessarily, it's not a plant that they're giving somebody, it's being derived. So to that point, I think, again, it's where things are kind of going. But in terms of ketamine assisted psychotherapy, is Spravato assisted psychotherapy, um, there are a lot of different ways to do it. I mean, and again, in this, what I'm going to be giving you all is sort of what's done, what we can do now with people who are using their health insurance in terms of what's covered and how we're able to kind of collaboratively work through the experience with a patient. And I'm going to be throwing a lot of information at you, but just to give you some context as far as like training for this as a therapist, I think the shortest I've seen is about 6 weeks worth of training at about 20 hours. And then the longest I've heard is there are programs that are a year long. So it just depends on, sort of what you're wanting to do. So there's a lot out there. Actually, I was at the Psychedelic Medicine Association last night, like looking through their training recommendations. And yeah, the range was 7 weeks at the shortest and over a year at the longest, depending on not just depending on which compound you're using, but how long you've been a therapist, where you want to focus, what kind of practice you want to have. So there's a lot of variation here. So we're just giving you a snapshot of um, one method of doing this. And again, keeping in mind, even looking at the chart that Arif put up, that's how many compounds are out there. That's going to be probably how many options we have in terms of how we're going to address this in the future. So the way we do it is a two provider model. We're trying to do collaborative practice between the prescriber and the psychotherapist. It can include ceremonial tradition and indigenous cultural practice at the request of the patient. Personally, I'm not trained in the ceremonial tradition or indigenous cultural practice. So that's something either I get consultation on from somebody that I know in the community or I refer out for that. Those unfortunately are not considered, interventions that are clinically relevant to be covered by insurance. So there's no codes for those. But we do talk about it, and I do allow that to kind of come in because, again, with some of these experiences, there is some sense of ceremonial practice for some of the patients that come in to see this in terms of their experiences. Comprehensive assessment and screening are really important prior to session. Um, on the psychiatric side, the doctor needs to be able to, or the prescriber needs to screen for, as Arif mentioned, psychiatric appropriateness for the medication. There's, medical clearance that needs to be done for a lot of these in terms of, if you have any medical issues or any history of psychosis, that needs to be looked at. And then for me, when I see a patient, we look and see at, what's going to be possible in terms of them getting prepared for their experience. And I'll delve into that in just a bit. So we talk about, preparation and expectancy of the client with regards to the ketamine experience, integration of experience, as well as reviewing treatment goals moving forward. So the idea of this is really to, again, get them ready for the experience as best we can. And so we start off, really looking at their goals, looking at what they're trying to accomplish in doing this treatment, getting them ready for a situation where they may not have a whole lot of control over what happens with them. Because again, once you take the medicine, you're what they used to tell me in training is you're on the ride. You can't get off the ride once you've started. So you're kind of having to go with it. So as much as we can get you prepared at the best. Um, what I really like to focus on with my patients is not just the idea we're doing it in a clinic. So obviously we're looking at physical safety, but I like for them to consider emotional and mental safety when they walk in too. So it's another reason why we do a lot of preparation. I try to give them grounding techniques before they go in, and then also have them think about if you're going to be in the room, wearing comfortable clothes, making sure that you've got, comfort items with you, whether it be a blanket, taking in your own pillow, having on comfortable socks, slippers, whatever it is you want to do. I have patients who take in, stuffed animals in some cases because it really does help them soothe. Um, we also talk about music and other things in the environment that can be helpful. Um, I don't make it a big point around their music choice. There are plenty of music playlists on Spotify for psychedelic therapy that are out there that are in public view for them to see. I think same thing on Apple Music. You can find quite a few playlists out there that are already curated together. My only advice to patients is to make sure that they're not putting anything in that is that can affect their mood. just because you are so susceptible and vulnerable in the condition when you're taking the medication. So I like for them to feel comfortable when they go in there, but I also don't want anything to distract them from the experience. And then also talking to them on the back end of making sure that they have a safe space to be in after they leave treatment, that they know that they shouldn't drive, they know that they shouldn't be making any big decisions that same day, they can't go back to work. Um, and that they may or may not want to be seen by their therapist the same day, but it will have to be because of insurance limitations, you have to be sort of discharged from your treatment in order to see a therapist in order for us to be able to bill. And that really varies depending on the patient. I mean, the optimal, and this really is changing as they're doing more research. The optimal used to be between 24 to 72 hours. Now they're talking about it being up to a week that you have kind of that optimal neuroplasticity for you to do the therapy with patients. And so most of my patients are seen within the 72-hour window, though. Sometimes we have to push it if necessary, but it just depends on the patient. And again, the other piece that I'm very focused on when I work with the patients on this is making sure that they have a voice, they have agency in their treatment. Because again, this is their treatment, and knowing that we have to kind of be flexible and pivot as needed because things come up. We may go in thinking that we're going to be doing nothing but depression work, and then they have a memory that triggers a little bit of PTSD in them, and we end up having to shift our focus moving forward, or at least for a few sessions. So, again, I think that's really important as well. Um, and then also talking to them about expectations of the experience. I think some patients walk into this thinking, oh, I'm going to have, like a big psychedelic trip and I'm going to see colors and pretty stuff and, all these things. And I mean, there are some people who absolutely do have that experience, and then there are others who are really afraid of seeing something awful. And that's always a possibility too. But then there's also the thing of, I think, being disappointed of what if nothing happens, where you just go in, kind of take a nap, or don't see anything, or don't experience anything. And the fear of, oh, well, what if nothing happened, or nothing, or it's not working? Because the other thing that I also tell patients is the after effect of this, the medication doesn't stop working in the chair. Once you get up and you're done, it could keep going for months afterward. You can still have that after effect for weeks, if not months after, in terms of the therapeutic value. And so just because you're not seeing anything happen immediately doesn't mean that within a week or two or a few months that you'll start seeing different things happen as a result of your exposure to the medication. Um, Arif, can we move the slide over? Okay, so yeah, as I said, in terms of like the typical psych intake and doing the developmental history, we want to get everything we can under our belts as far as what's going on with the patient, asking them about what meds they've done, um, if any other psychedelic experiences that they've had, or any other psychedelic medicines they've had, any history of substance use, any history of experience with non-ordinary states of consciousness, religious or spiritual history, any other treatments and interventions that they've tried, outcomes, takeaways. The other piece of this too to keep in mind is sometimes you'll be getting patients who come in for Spravato who have done ketamine in the past, or have done some, or this is their third or fourth round doing ketamine or Spravato after they've done it before a few years prior, and they're coming back in for maintenance treatment. Because again, there's a lot we don't know about how all of this works, and a lot of this is still a work in progress. And so I've had a handful of patients who did ketamine 3 years ago and are now doing Spravato, and found ketamine really helpful, and then stopped for 3 years, and now they're back trying to do this again and have that experience coming in. So sometimes it's good to ask those questions because again, you may not be getting them on their first time in. You may be getting them on their second or third time, potentially. Let's see. And so then, again, getting more information. What brings you to ketamine? What would you like to get out of it? What are you hoping the ketamine will do? And what other kinds of treatments have you tried? How were they? And so again, you want to get a handle on what they're hoping to gain from it, and helping manage expectations. Because again, for some patients, they think that, treatment course, I think for now is about 8 weeks. Arif, is that right? Yeah. Um, so it's about 8 weeks, and I think the expectation is, oh, I'm going to be cured in 8 weeks. And as I said, we do see response and remission pretty quickly, but at the same time, it's a journey. So I try to give patients also the information of, this is going to take time. Um, we're For many patients, this is their fourth, fifth, 10th intervention on their depression. And so they've been through, quite a few failures at this point. They've had lots of life before they get here. And so if they have any history of anything, we have a lot to unpack, I think, as we start going through this. So I try to give them that lens as well, that, a complex life ends up needing complex treatment. And so it takes time, and to try to be patient with it. Um, and that it's also not them, it's not their fault if it doesn't work. Because I think sometimes patients will say, oh, I didn't do it right. And there's not a not doing it right, I think, in this. It's just making sure that they're prepared and know that one just because they had one session where they didn't feel anything doesn't mean that the next one won't be really powerful, or vice versa. Because a lot of these will, again, won't necessarily be the same thing every time. And then, again, with the risks and benefits, giving them some psychoeducation, medication side effects, as Arif already mentioned. And I think this is also a point, and two, same thing, notable exceptions regarding abuse and violence, etc. This is where the collaborative part is really important between the therapist and the prescriber, of getting information and kind of looking and making sure both of you are on the same page, that you know what's going on with the patient, what they have going on at home, if there's any safety planning issues, um, and making sure that their treatment team is all aware of what's going on. Because again, sometimes people will disclose something to me and not disclose it to their prescriber, or vice versa. And so we just want to make sure we all know what's going on. So an important, like one example that, I like to give is that we had a prescriber at one point see a patient was adamant to get treatment, and the prescriber was concerned about the patient's need to come in, even though they met criteria, so to speak. He still felt like it was a suspicious kind of thing. I got more information and found that there was domestic violence in the house, and that the reason that the patient wanted to come in, which they did not disclose to the prescriber, but they did disclose to me, the reason that they wanted to come in was because their partner had an ulterior motive for them to go into ketamine treatment, because they wanted to be able to reprogram the way they think about their marriage. And because the partner had apparently done some research on what this can do for changing your thoughts. And so I actually ended up telling the patient, you know what, I don't really feel comfortable with you doing this. You're not in a safe
Mhm.
environment, and giving that psychoeducation, and then going back to that prescriber and saying, thank you for sending her to me, because she would have just done the appointment and gone and done this. And maybe it would have been a really unsafe thing for her. And she wound up staying in therapy and ended up not getting on medication, because it was a domestic violence situation. And so, again, I think this is one of those where, again, risks and benefits are really important. That collaborative piece is really important too, because you sometimes don't have all the information going in. And this is why I think collaborative practice is so important. Um, and then, so making that plan after session, there we go. Outlines for navigating the experience and including challenging experience. So talking to them about, what all they could possibly experience going in, any anxieties or concerns about the experience, helping them minimize stress. So this is where, I kind of talked to them about, um, being comforted going in, any grounding exercises we could possibly do, meditation, breathing, anything they could have with them. A lot of the time I will send them, videos or recordings of things, so they have it on their phone. So if they have trouble relaxing in the room, they've got that on their phone to have access to. And clarifying the values of what's coming in, going into this with them. What do they want to get out of this? Um, and then, reflecting on their intention and their goals for treatment, short-term versus long-term, and reviewing expectations again. Um, because as I said, going into this, there's so many things that can happen. I want the patient to really feel like they've gotten all their questions answered before they make a commitment to do the treatment. And then as far as making a plan for after session, we tell the patients that they need to find someone to take them home afterward. They will be impaired or not able to drive. Being in and creating a safe environment post session, whatever that might look like. I know with some of my clients, I will say to them, maybe don't be the one to cook dinner when you get home later, or maybe get, a couple of hours of a break when you get home and not have responsibilities for a bit if you need to. Journaling or recording the experience through art, music, and other cues can be really helpful, I think, in some cases, depending on the patient. Um, and remembering, that whatever is important that you experienced or want to hold on to, you will remember it. All of the experiences that you have are going to be valid, even if they don't seem to be important at that moment. They may make sense later. Um, and whatever comes up is relevant and valuable. Again, you may not see it at that moment, but a few weeks later, a few days later, you may find that you see a connection between something you saw and something that you're struggling with at home, or in your daily life. And then in terms of integration, so assisting with challenging or intrusive thoughts and feelings, so trauma processing. So some of this may come up, again, post session. Sometimes I will tell my patients, if you want to take a journal in or want to make notes while you're um, in your session, sometimes I tell them, like, make sure that you have the recording option on your phone when you're in there, if you want to take some voice notes while you're in the experience, or take some voice notes when you get home. Um, and then looking at maybe some of the insights that they have and seeing if there is a way for you to connect them to daily life. A lot of my patients who come in to do this, we do a lot of cognitive behavioral therapy or a lot of dialectical behavior therapy to help them reframe, go on. A lot of my patients come in with, treatment resistant depression, automatic negative thoughts. And so some of that is part of their treatment plan when they come in. And then, again, coping with changing beliefs, identities, worldviews, because some of this also might impact them when they're going through the treatment. Some questions might come up. They may see things or experience things that make them wonder about previous beliefs or previous experiences, helping them navigate relationships and intimacy. Another thing, and this goes along with not just with the integration, but the pre, kind of planning before, is also looking at who do they have in their lives that they can talk to about this, because for some of our patients, there are some people in their lives they will not be able to tell that they're going in and doing ketamine or Spravato because of maybe judgments or stigma. And so making sure that we address that as well while we're looking at integration, but then also pre-planning. And then trying to maintain positive benefits. And again, that's going to be an ongoing thing with the patient that you do during their treatment planning process, and then continue treatment interventions moving forward. And then, again, also letting them know it can be really ordinary at times. It's not necessarily going to be, grand realizations every time they go in for treatment. Some of these things can take time, and some of it, again, can be pretty, underwhelming, I think, for some of them, as they expect bigger things. And then, again, going back to sort of some of the challenges that come through, our desire for fast change, they want things to happen quickly, frustration with the slow pace of psychotherapy, and, wanting to, sort of have a quick fix. And, again, lack of ongoing support for ongoing change, and ketamine as a panacea. I mean, and the overemphasis on drugs, the drug effect is being curative. And for a lot of this, I mean, this again starts off part of that pre-planning phase. We have these conversations with patients prior, but at the same time, walking them through this, because again, it's a process. And I think for a lot of our patients who come in who have treatment resistant depression, this isn't their first time going through getting treatment. They've probably had other treatments fail over time, and they're frustrated, and they want to hurry up and see something good happen for them. And so I think, again, being able to validate that and help them move forward and manage some of that movement speed and flow through therapy, can be really helpful here. But there are going to be times when it is difficult and kind of challenging, to maintain that process, and for them to want to maintain that process. Um, again, what if nothing happened? And like I said, if they don't have, a big, great experience, going through that with them and talking them through and normalizing the fact that that is disappointing. Um, and then having those unresolved psychiatric symptoms. I mean, that's another point where, as I said before, it's really important to have that relationship with the prescriber because that may be something, again, they're bringing up with you, but they may not have told their prescriber that they still have those ongoing symptoms. Um, and then that disappointment and self-judgment about, spiritual or psychological capacity, not even ketamine worked, when symptoms return sometimes. And again, having that tandem back and forth with the prescriber is really important here because this is maybe an opportunity for psychoeducation or looking at different methodologies that can be used in tandem with therapy or looking at, again, how you might incorporate other therapies with other therapists outside of just yourself. I mean, I know looking at this, as I said before, there is a lot of information that goes into doing, ketamine assisted psychotherapies, Spravato, and then looking at the other compounds that are coming down the pipeline. All of these have, I don't think that there's ever going to be a therapist in the future that's going to know every single intervention that can be done in integration and post psychedelic treatment. I think we're going to have at the very least a collaborative process with the prescriber, but I think at the same time we're probably going to need to build a village as a bunch of therapists and clinicians in the network because some of us are going to be really good at doing certain kinds of intervention and then we're going to need supplemental intervention and probably a collaborative process moving forward. And so I think it's a good, I like the idea of giving our patients that village, but then simultaneously giving ourselves that village too, because we can't do this by ourselves. This is challenging work and we're all still learning. And so I think in this, it gives us a chance to kind of see where we might be able to bring in other collaborative people into the system for the patient. Um, and then bridging various routes of ketamine use and various frequencies. So some of this is going to look different depending on the patient. I mean, I think, again, the traditional way of going through it right now is that 8-week course. Maintenance is going to look different for everybody. There are some patients that I've seen who finish their 8-week course and they're done. And then there are others who continue every week, every other week, once a month, once every 3 months. And all of that is going to look different for everybody. And as Arif brought up before, depending on the routes of administration, affordability, accessibility, those things can actually also change what they do in office versus at home. And then I know with some of the rules and regulations that are kind of going up before the legislature, and I think with the boards, there might be some changes in what we can do with ketamine and some of these other compounds in the future, as far as whether or not you can do them at home or it has to be in clinic. Um, and so looking at some of that and just making sure that we all know sort of what's accessible, what they can use, and maybe bridging that gap if need be, because there are so many things that are available out there now. And so these are some sample early integration questions that, I send patients to kind of think about um, before, during, or after. What's your intention behind, doing ketamine work? What have you received from ketamine experiences so far? What's the experience like for you? What does it mean? Have you identified any obstacles to integration? Why do they feel like they need help? What do they need to gain? What do they hope to gain from integration? What would it look like if integration were successful? So if you look at some of this is looking at, kind of solution focused brief therapy. But you're also looking at, again, too, motivational interviewing, looking at, again, intention setting, and then, working through, treatment planning and problem solving with them. And so getting them to really think about what are they expecting? What are they hoping to get? And is what they're hoping for attainable at long term versus short term? But really getting them to have a voice in this and them figuring out where they sit in this. Because I think too, sometimes patients will look at this and go, oh, well, it's a medicine, it'll take care of me. Um, and I mean, I think, that's how we've been set up, I think, for a long time is you take the medicine and then it does its job and, you're done. And this is more of what kind of work do you want to put into this? How do you want this to work for you? And again, if it were successful, what does that even mean to you? Because I know what it would mean for me for a patient potentially in terms of like symptom reduction, right? But that may not even be where they're going with that. It may be something completely different in terms of just feeling happier or feeling more connected. Um, and so again, it's just making sure that they kind of have an idea of what they're looking for in this. And again, them having the voice and the agency in their treatment moving forward. And then there are just a couple of things in terms of further reading because there is so much there. Ketamine papers is kind of was what was given to me at the beginning when I first started working in this part of the field. It's a really intense book, lots of information. There is one for psychotherapy in particular. If you're looking at psychotherapy, there is one chapter toward the end of the book that can give you some ideas in terms of where to get started. Um, the the two that I really want to highlight though is Psychedelic Integration by Mark Aishala. He actually has a great book. It's really dense, but it covers in a really nice way in terms of all of the things that you have to take into consideration and what all you can do with the patient. And doesn't keep it really narrow. I mean, it's a much more open, like broader focus as far as what you can do working with patients, and then the ethics of caring. Um, the ethics of caring, I think, is a great book in the sense of just giving you an idea of how you support the patient, what the best ways are, and then, again, some things in terms of checking yourself as far as how we can get in the way. Um, because I think sometimes too, like one great example that she gives is, you can want the patient to get better in a way that they don't want to get better in. Like your goal might be different than theirs, so your agenda is different than the patient. And I mean, it's not like you're not committing some great cardinal sin, right? But you are holding them back if their idea to get better looks different than yours. And so being able to be honest with yourself about what role you're playing there and how much of your agenda might be at play in that moment. And again, I don't think that any patient hopes to do any harm to a patient. I think that most everybody working with these patients wants them to get better, but again, depends on whether or not we're on the same page. And so just making sure that we look at it thoughtfully in that way. And then the American Society of Ketamine Physicians, Psychotherapists, and Practitioners has a lot of just basic general information. And then ketamine for depression um, is another one to be, you can look at for more general information. But also keep in mind, to Arv's point, like there is a lot of emerging information. Actually, on LinkedIn earlier this morning, I saw they did a meta-analysis they just published of like 1,300 patients over 6 studies in terms of what they're looking for. And the numbers look really great, but again, this is still emerging, and everything on the psychedelic side is still really emerging.
Yeah. Thank you so much, Andrea. There's a lot, obviously, to cover when we're talking about preparing and working with patients that are getting ketamine treatment. I think you did like a fantastic job of very, very succinctly kind of summarizing the high points of that. Let's go ahead and open it up to a little bit of Q&A. I know there's some questions in the chat, and I know the first one was about kind of this idea of optimal timing of therapy in conjunction with ketamine. So you will find some people in the community that feel very strongly that the optimal time for therapy is in conjunction with ketamine. So like while the patient is actively intoxicated on ketamine, therapy be done. Um, I haven't seen any like robust evidence thus far that that's true. But there is emerging and good evidence, and like every psychotherapy, set of research, it's very difficult to do, and you need big numbers to get the solid results. But there's more and more evidence that this idea of a window of like 24 to 48 hours is not really accurate. That we're inducing this kind of like pulse, this burst of chemicals in the brain that stimulate neuroplasticity, and that kind of like peaks and kind of tapers off. from a single dose. But for patients who are getting ketamine treatment, they're getting it twice a week for 3 weeks for induction usually, and then weekly thereafter. And so what we're doing is inducing kind of this whole long period of increased neuroplasticity. So patients tend to get really anxious about this, but I try to dissuade them from worrying about it. As long as we're getting both treatments in during the week. When that happens exactly isn't as important to me, and that's what the data says too. Um,
Um, and then Nancy, what I can do actually, let me look for it. And if Julie, are you going to send this out to everybody?
Yeah, I'll send a follow-up after the blog is posted. So typically that's in the next like couple days after we download the video. And we can add that link in there too.
Perfect. Yeah, that's what I want to go ahead and do and try to find that because I didn't get to read the whole thing. I just got to see the little abstract and I was excited to see some of the numbers coming up. So hopefully, yeah, we can get that to you in the next couple of days.
Wonderful. And then Dr. Toll, would TMS and ketamine be a useful combination? TMS every day and ketamine 2 to 3 times a week. I don't know of any evidence to suggest that this would be like higher risk to do things in combination. And I know that there's been a lot of case studies of this done. And when you think about it from a theoretical standpoint, kind of, ketamine is increasing neuroplasticity. TMS is trying to kind of modulate connectivity. And if the things are more plastic, you can modulate that connectivity maybe a little bit easier. And so it's a really interesting idea. I don't know of any kind of blinded, kind of higher level of evidence studies on this, but I know a lot of case studies that have shown good results with combination treatment. It's just kind of hard to get, two interventional treatments covered by insurance usually, if we're using insurance for this. So thank you, Russ. Any other questions today? It's a lot to kind of think about and talk about here. Okay. Um, all right. Well, with that, I hope we kind of leave you with the idea that, these are going to be much more common treatments. It's a completely different paradigm from what we've been doing in psychiatry and mental health for the last, decades. In terms of the siloed med management, siloed therapy, really this collaborative care model is really important to driving better outcomes, and I think all of us are going to have to get a lot more comfortable with it moving forward because this is probably the way these are going to be administered. All right. I hope everybody has a great day. Thanks for coming.
Thanks, y'all. I'll send out an email with a recap once we have the video posted. And please, if you have questions that come up later, feel free to email us. We'd love to hear from you, especially if you do get a new client or patient in the future that is interested in learning more and you have questions. So we're here. And thanks so much. Have a great day, y'all.